Hey everyone. Let's get through a quick scenario. What is this one? Altered mental status. Hey, a minute. This isn't supposed to be that. Stand by. Pause recording. Okay, I could see where I got confused. This is a seizure, but it's going to get dispatched as an altered mental status. So apparently you only get 8 minutes to run the station. I don't know why, but whatever. EMT partners, under equipment, you have a patient and a bystander. Well, that's good. Make sure you bring those with. No first responders. I didn't write this. All right, so you got a first in bag with oxygen. You got a radio and a stretcher. Well, that's helpful. You are dispatched for one who's unresponsive. Let's see. You're seen. The male is found laying in a college hallway. Patient's dazed and confused. The movie, for the kids in the room, there's a movie called Dazed and Confused. When EMT arrived, bystander said patient need for a moment, and then fell to his side, maybe kneeled. I'm guessing this is kneeled. Again, this is dispatch info. We get misspellings all the time. We have no idea what they're saying. So whatever. You walk in and the bystander's saying that the patient fell on his side. 24-year-old male, he's responsive to verbal stimulus, but they don't say how he's responsive. Airways patent, normal breathing, slightly flushed skin, hot, dry skin, no bleeding. His name's Gregory, that's what I'd call him. And lost consciousness, no allergies. He's got a history of epilepsy. Interesting, takes Keppra. Wait a tick, he's 24 and in a college hallway. Oh, okay, might be a college student. I thought it was a dormitory. He ate lunch. Well, that's good. I need to eat lunch. Patient was in class, felt an aura coming on. They don't all feel auras. Patient left class to find a private spot. And he's been inconsistent with taking meds for the past 2 weeks. Well, yeah, he's a dumb 24-year-old kid. He's named Greg. He takes Keppra. Okay. Heart rate 110. All right, that's fine. BP 110 over 6. Usually that's a bit higher after seizure in my experience. I'm no expert, but in my experience. Respirators is 16. Usually that's higher too after seizure. 96%. Sugar is 106. That's fine. He's got normal temp. All right. Cute. Let's run it. Wait, real quick. What do we do? Actually, I know what we do. God. All right. I'm going to share different. New share. I found that button today. Okay, so you've got your SOAP template up. And we're going to title this Seizure. Yep. Seizure. Dispatch reason. EMS is dispatched to a college building, to a hallway inside a college building for one who done passed out. Chief complaint. Now again, if you get someone who's altered mental status, who's confused and incoherent, usually after seizures they are because they're postictal, it's not like you're going to walk up to a postictal person and say, hey, what's going on today? They're going to be super confused. So who's the most reliable person on scene? Well, it said you have a bystander. So bystander reports he observed patient slump over on the floor in the hallway and convulsing. Bystander reports the convulsions. Oh my gosh, convulsions lasted about 1 minute and involved patient's entire body. Because I would ask him, were the convulsions everywhere or in just one part? And say, no, they were everywhere. That's all right, sweet. Onset, we have no idea what started. Bystander reports patient was in class when he stood up and left to go into the hallway. Bystander maybe reports patient appeared confused. Left the classroom. So he had the aura. But the bystanders are going to say, well, he had his aura. They're not going to say that. Now, does anything provoke your seizure? Well, yeah, not taking your Keppra like you should, Gregory. But you can't really say provokes. It's not really quality. Can you describe the quality of the seizure? You can't really say that. It's a full body tonic-clonic grand mal seizure. Radiates, does your seizure radiate? No. On a scale 1 to 10, rate the seizure? No. Times and events preceding, that's about it. So we can take all that away. Cool. Now we can take that away. And we can take that away. And there we go. So secondary complaints. Patient's incoherent. He just had a seizure. He's post-ictal. He's not going to tell us much. And pertinent negatives, afraid not. He's probably not going to tell us that either. Maybe later on he might. So I might say something like, after patient becomes more responsive and alert, less confused, patient reports no headache, dizziness, chest discomfort, or difficult. I need glasses. I got a teeny computer. Breathing, nausea, or abdominal pain. Let's say that. Now for this guy, given that it's a seizure, I'm going to ask him more questions. Patient denies, because what else could cause a seizure, right? It's not just the seizure itself, but recent illness. Patient denies recent illness or fever. And what else could? Well, trauma could, right? So patient denies recent trauma or injury. And when I talk to people about this, I ask them even minor stuff like low-level accidents. Were you in a kickboxing class and got just nailed in the head or dropped on your head? You never know, right? It's not just head. It could be internal injuries as well. And then I'm going to ask him, patient denies, what else could have changed? Well, he could have changed his medication. A lot of times with seizures, they like to adjust or change meds. So while you're taking them off of one med, that therapeutic dose goes down. They're putting them on another med, that therapeutic dose isn't quite there yet, and people can have seizures. Keep in mind that a seizure brain, again, I'm not an expert. I'm sure a neurologist would watch this and have a field trip and think paramedics are dumb. But we're not. I swear, we're not. We just haven't studied the brain like you have. But as I understand it, the way I like to think about that is the epileptic brain always wants to seize. It's always ready to go. These medications do not let it happen. But if you take the medication away, or you increase it, or minimize it, or reduce it, or change it, the seizure can break through. It can be expressed, right? But the brain's always ready to go. So patient denies recent medication changes. There you go. So those could be secondary complaints or pertinent negatives. I put it under secondary complaints. It doesn't really matter. But those are pertinent negatives. And he has no secondary complaints. And I might say, bystander reports patient did not fall when the seizure began. Patient kneeled on the floor, slumped over. So I would say that, because now you just took out C-spine, right? Okay, allergies, no known diagnosed allergies. Medications, Keppra helps if you spell right. That's an anti-seizure medication. Epilepsy, did I spell it right? Look at that. And last food or drink. He had, what did he have? A bowl of Frosted Lucky Charms. Yum. Lots of sugar. Good for focusing. And a cup of Easy Mac with chopped up hot dogs. Get it? Because they're my dogs. God, never mind. And ketchup. Haha. And the ketchup. Ketchup? Yeah. Sounds pretty good. All right. Age, gender, position, location. I typically start my reports with this information. Patient is how old is he? 24-year-old male. Found sitting on the floor in the hallway of college building with bystanders on scene prior to arrival. General impression, let's say patient is wearing a hooded sweatshirt and Crocs. Crocs with socks, I'd remember that. Boy needs help. Patient is alert with confused behavior initially. Patient appears post-ictal. Patient's mentation improves gradually throughout. Patient contact. Patient becomes AO times 4. Because the post-ictal will wear off, and they'll come back around. It might take 20 to 30 minutes, something like that. Okay. And for this guy, I forgot in this skeleton or in this template, I always do neurologic assessment as well. You're always doing it anyways. So no neuro deficits. Speech is initially slurred and incoherent, but improves non-slurred and slurred and coherent and appropriate, sorry. No facial droop or extremity deficits. I always put that. Again, the patient didn't read the textbook. Just because he's a young man doesn't mean he can't have a stroke. I had a 8-year-old, 9-year-old having a stroke. It's the youngest stroke I've ever seen. Poor kid. Breathing. Now, there's nothing really about his airway. Now, you could say he probably bit his tongue. So, airway. EMS notes, no. EMS notes, patient bit his tongue with no breathing is non-labored, no abnormal sounds. Lung sounds are clear and equal. Okay, now we're going to go down into circulation, pulses, strong, regular, radial, pulses, trauma. Oh wait, skin color. Skin is, what was it? Flushed and red initially. Skin improves. Usually these people are clammy. I don't know who wrote this, but usually these people are clammy. Skin improves to pink, warm, and dry. No head, neck, or back pain. No bleeding, trauma. Okay. We can delete that. Delete that. Delete that. Through and delete all that stuff. And there we go. There's a pretty good objective. Okay. Assessment. Curl. That's about it. There's really nothing else I'm going to say about the eyes or about the head. Normal. Chest. Equal. eyes fall, clear equal lung sounds. Abdomen, soft non-tender, soft non-tender, my goodness, times 4. I'm not palpating this guy's abdomen, I'm just gonna put it in here because someone's gonna ask for it. CMS times 4, intact, cap refill, less than 2 seconds. Again, I'm not putting this in here in my own report, this is just to satisfy the requirements for you, but I don't put this. I have different stuff for that. Vitals, I'm gonna let you put the vitals in yourself to save time in this video. So, on-scene treatment, what we want to do, we got to check a few things, right? We want to assess the patient first and foremost, give him oxygen if he needs it, perform a stroke assessment. I would always do that on anybody. Check a blood sugar, check a temp, and then see what the patient wants to do. If the patient is not taking their Keppra, it means they're likely going to have another seizure. And so for this patient, I would talk to this patient about, we need your Keppra. Like, do you have it with you? Did you miss a dose? What happened to where this seizure happened today? Maybe he's like, no, I don't have it with me and I can't get it. Then he's got to go to the hospital. There's no alternative because he's going to have another seizure. He needs his Keppra and he needs to get, so let's say this patient has his Keppra with him. Let's say that, sorry about that. Let's say this patient has his Keppra with him, or he took his dose. Now let's see what the scenario says. I'm going to pause video real quick. Okay. I'm going to stop share real quick so I make sure I'm sharing on the right screen. Screen share, my document. Okay. So we're going to say this patient's not going to go to the hospital. So patient is assessed, because they usually don't, on scene with physical exam and vitals. EMS notes patient had generalized seizure and is now post-dictal. EGL is assessed. EMS remains on scene with patient and notes patient's mentation improves significantly. Patient becomes AO times 4. EMS discusses patient's condition. Patient reports he did not take his Keppra medication this morning. Patient has his Keppra with him and takes dose with EMS. Now we'd want to have someone with the patient during this, right? So EMS speaks with patient's friends on scene who will remain with patient and monitor his condition. This is a refusal. These are hard to write. Patient states he feels he is okay and does not need to go to the ER today. And I would just put in here, EMS offers transport to hospital for further assessment. That's how I always write my refusals. And I say, patient states he feels he's okay and he does not need to go to the ER. And then we got to speak with somebody. We need someone with him, right? Either friend, boss, coworker, girlfriend, boyfriend, someone responsible. Mom and dad, if they're nearby, we can do that, call them up. But he doesn't want to go in, that's fine, he's an adult. But he's going to be with friends who are going to remain with him on scene and monitor his condition. So EMS advises patient and patient's friends to contact 911 if patient's condition changes or they have further concerns. That's how I end mine all the time. Not just if it gets worse. If you have further concerns or if anything changes, call us back. We can come back and check you out. So to me, those words kind of, it's a nice umbrella term, right? I used to go way too in depth on this. It took me forever. So patient signs refusal and left on scene with his friends. And I'd also put in here something like EMS advises patient to take his prescription medications on time every day to avoid future seizures. So there we go. There's probably the world's best narrative for a seizure patient ever, I'd say. Just way better than Sarch's, way better. That's it, there you go. I hope this helps. Let me know if you have any questions, and that's all I got for you. Stop share. All right, see you guys.